Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. We have a patient who attended with bilateral, fully occluding earwax, and they have to attend twice a year to have this removed. We're commencing with this their left ear first. Do stay tuned for their right ear. Their right ear canal is extremely narrow. I would say that the width of their right ear is approximately half of the normal width of an average adult's ear canal. And the average width of an adult's ear canal, it does vary along different points of the ear canal, but it's around 0.5 to 0.7. And in this patient in their right ear, I was only just able to insert the zonar suction probe, and the diameter, the outer diameter of the zonar suction probe is 2.1 millimeters. So by those maths, the right ear canal's almost half the normal width of an average ear canal. And when you've got a narrow, bendy, twisty ear, you're just more prone to getting wax buildup. So as wax migrates out of the ear, so the wax is sitting on a layer of dead skin, and this skin, as it's dyed and shedding, it migrates sideways. We call it the epithelial migration. It's probably we've all had the great wildebeest migration, and I would say that that's the equivalent in the human body, the epithelial migration in the ear, and it takes around it's 1.5 mil to 3 mil a month for the skin to die and shed and move sideways. So it sheds about 1.5 to 3 mil a month, and if we average out the ear canal to be it's 2.6 centimeters, but if we say it's 3 centimeters, so it can take up to 10 months for the wax to migrate out of the ear. And as the skin migrates, any wax sitting on the surface is also transported out of the ear. So we've cleared the occlusion. I'm just using the fine end suction probe now just to go around the edges. We've got to be careful. We're on the bony part of the ear, so we don't want to make contact with this portion of the ear canal because it'd be very uncomfortable for the patient, and no doubt they wouldn't come back again. So we've got to be very careful. We want to make it a comfortable, almost pleasant experience if possible. Now, having your ears clean, I wouldn't say, I'm not going to lie and say it's the most pleasurable experience you'll ever experience, but if we can make it comfortable for the patient, obviously they're going to be happy. They're not going to be traumatized. I know you get a lot of patients who have phobias when they go to the dentist, and also patients who have phobias of people entering their ears as well. So we've got to be gentle. I'm just hovering over the top. Anything that I'm not feel comfortable with removing because I'm worried that we may touch the canal wall, or the patient, corner of my eye, I can glance towards them and I can see that they're probably finding it uncomfortable. We leave, because all this is not going to improve the hearing. It's just mopping up the ear. Might just add an extra few weeks until the next time we need the wax removed. But so far, this is risk-free. We're just hovering over. I'm using the fine end suction probe, so it's minimal noise. We're working here now laterally. And this is all skin, so the skin that I made reference to earlier, the epithelial skin, it's dyed and it's shedded and it's just moving sideways out of the ear. There's a little bit here posteriorly on the canal wall. We're probably midsection of the ear here, and it's not that game of operation. We want to hover over the canal without making contact. When we're on the cartilage portion, the outer third, then applying a bit of pressure is not a problem, because the cartilage portion is not sensitive like the inner 2/3, the bony part. Also, the cartilage portion has a thick layer of skin, about 1 millimeter in thickness, which provides like a buffer layer. And the skin has 3 membranes. The innermost membrane, we call it the subcutaneous layer, that's full of insulating fat and connective tissue, so it protects the cartilage. Whereas the bony part, the inner 2/3, so it's only a thin layer of skin. It's only the epidermis, the outer layer of skin, which is less than 0.1 millimeters in thickness. So as you can see here, this is their right ear. It's extremely narrow, and I could just about squeeze in the zonar suction probe. Using the fine end for that just wouldn't be powerful enough, unfortunately. On a block, This patient's wax was quite sticky, so as I was removing it, it kept blocking the suction probe. So using a fine end to get through that narrowing, although it would have got through, one, it wouldn't have been powerful enough, and two, the fine end would keep getting blocked because it's got the internal diameter of a fine end to suction tube is about just over 1 mil, 1.08 thereabouts, whereas the internal diameter of the Zollner suction probe is about 1.7. So once we're through the narrowing, the ear canal widens, and the patient has reported having difficulties in the past elsewhere, having this particular ear wax removed in this ear. They'll struggle to get through that narrowing. Now, the patient had been using drops. I prefer this particular patient not to use drops because they've got naturally wet wax anyway. I think they were using it in the hope that it would just clear out the wax and break it down, but as explained, that ear drops doesn't really do that. They are softening agents, and in fact, they can make your blockage worse. So the skin in the ear, 60% of the dead skin is what makes up earwax. The 60% of earwax is dead skin, and skin is hydrophilic. It absorbs water and moisture. So if you're using softening drops, which are water-based, like hydrogen peroxide drops or sodium bicarbonate, the skin cells contained within the wax plug absorbs it. It causes the skin to swell, and as such, the blockage of the wax gets bigger. In addition, even olive oil is a softening agent, but it can temporarily make the earwax plug bigger because that oil adds a veneer, it adds another coating to the wax plug. So 60% of a wax plug is made up of dry matter, so dead skin, hairs, any debris that forms in the ear, and that forms into like a matrix. And then the remaining 40% is wet matter. It's an oily sweat secreted by somonas glands. We find it under our armpits as well. And sebum, which is the same secretion we find in our scalps. It's an oily, fatty secretion. So they're both wet matter, and the wet matter coats the dry matter. So when you're adding more oil in the ear, when you've got a substantial buildup of wax already, it can increase the size of the plug because that oil is going to coat that plug and add another lacquer, if you like. So just explain to the patient not to use. They use water-based drops as well, and that's why they've got a bit of dead skin here. So that skin with water-based drops, when it swells, eventually it'll burst because it's only so much moisture that skin cell can absorb, and then the membranes break, and then you get a breakage of the skin. It leaches at the entrance. The surface of the skin. It breaks down. It just makes it more susceptible to infection, to bacteria and fungi. So kind of there's only a few patients that I recommend using drops prior to attending, and I would only know that after treating them for the first time. Patients with keratosis obturans, for example, for them I do recommend sodium bicarbonate because we do need to break that skin down a bit. There's a bit coating the anterior canal wall, but just want to be, it was very close to make contact with that because of how narrow the ear is. Patient could hear, eardrum fully visible. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.